Hi, thank you for coming today. I am speaking on behalf of myself and our genetic counselor, Jeri Milanovich, about hemoglobinopathies, the alpha, beta, and gammas of carrier screening, and I'm Barbra Fisher. So today, I hope to accomplish the following objectives, which are to review the importance of genetic carrier screening, understand types of hemoglobinopathies, provide a screening algorithm, and invite referrals to our genetic counseling team. Why do we do genetic carrier screening? There are lots of conditions that would benefit from screening at the appropriate time, and these include looking for aneuploidy, spinal muscle spinal atrophy, cystic fibrosis, hemoglobinopathies, which we'll address today, Fragile X syndrome, and for diseases affecting women of Eastern or Central European Jewish descent, otherwise known as Ashkenazi Jews. Carrier screening would ideally be done pre-pregnancy. That's the ideal time for conversation. So when you're seeing patients for annual examinations or preconception conversations. Carrier screening is about genetic testing on individuals without an overt phenotype. So it's just that. It's carrier screening. You're not looking for affected individuals. We can screen via a conversation, so talking to the patient about their history, their demographics, and looking at labs. And then genetic counseling is available if you're not sure where to go with this conversation, even in the non-pregnant state. What are hemoglobinopathies? To remind us, hemoglobin is a protein with 2 alpha chains and 2 beta chains that transports oxygen, and this protein is within the red blood cells. The term hemoglobinopathy refers to a heterogeneous group of single gene disorders. It's one of the most common inherited diseases affecting more than 270 million people worldwide are carriers or heterozygotes, which accounts for 7% of the world population. There are both quantitative and qualitative disorders for which I will talk about now, or talk about in a minute. The carrier frequencies are actually really, really common. For sickle cell anemia, 1 in 12 individuals who are African Americans are carriers, 1 in 6 individuals from West Africa. For the thalassemias, it's not as common, but it's still very common. For beta thalassemia, 1 in 20 individuals of Mediterranean descent, and alpha thalassemia, 1 in 20 Asian descent, and more than 1 in 20 for Southeast Asia specifically. What is sickle cell anemia? Sickle cell anemia has pretty profound manifestations. What happens is with the abnormal hemoglobin chains, it results in distorted red blood cells or sickle cells, as shown on this picture, leading to increased viscosity, hemolysis, and anemia. These sickle cells get stuck in the vessels, resulting in vaso-occlusive crises, and repeated crises result in microvascular obstruction, resulting in end organ damage to the spleen, the lungs, the kidneys, the heart, and the brain. I'm not expecting that we're going to find find women who have sickle cell anemia during our screening, but the point of this conversation is to find carriers, because if they are an asymptomatic carrier and their partner is an asymptomatic carrier, their offspring are at risk of becoming affected. The thalassemias, we don't see this often as well, but it's also about the offspring for 2 carriers mating. For alpha thalassemia, the most severe form we see is hydrops fetalis. Also, these affected individuals have anemia resulting from hemolysis, which leads to jaundice and hepatosplenomegaly, as well as organ damage. For beta thalassemia, it ranges from severe anemia requiring lifelong red blood cell transfusions, sometimes even weekly, to a mild anemia resulting in hepatosplenomegaly, pancytopenia, and heart failure. Women of African descent. We should assess for prior screening, since if these women have been screened for sickle cell anemia before, they don't need to be re-screened. The primary way to screen women of African descent is with hemoglobin electrophoresis, and other screening tests such as a solubility test that's on the market is suboptimal and discouraged. If a woman is affected as a carrier with sickle cell, please refer to genetic counseling/MFM. And this is because there are pregnancy-specific maternal recommendations for carriers. There's increased risk of UTIs. And even if they don't have sickle cell anemia, having sickle cell trait does require some extra surveillance during pregnancy. In addition, partner screening is going to be important to evaluate if there's an affected offspring. For women of Southeast Asia or Mediterranean descent, in red on this world map is areas of history. The first thing to look at is a complete blood count and red blood cell indices. The red blood cell indice of concern is an MCV less than 80, and what we're seeing with referrals to us, or we see patients for advanced maternal age and look into their labs, there are women who have normal hematocrits, but their MCV might be in the 60s, and it is marked in their labs as normal OB panel, normal results, and it actually isn't, depending on their ethnicity. So low MCV, even with normal hematocrit, warrants attention. And the attention, depending on the patient, their clinical situation, may mean iron studies, so look at a ferritin, and it may mean hemoglobin electrophoresis, depending on their ethnicity. Women can have both an iron deficiency anemia and a hemoglobinopathy. So a woman of Southeast Asian descent who has a hematocrit of 30 and an MCV of 60 and a low ferritin, they could have iron deficiency and also warrant genetic counseling. So please have low threshold to send these women for genetic counseling. If the hemoglobin electrophoresis is normal, that does not exclude carrier. Hemoglobin electrophoresis will be abnormal for women who are carriers for beta thalassemia. Alpha thalassemia requires a DNA test and is a secondary test. We've also seen this come through our clinic. Women have low MCV, they have a normal hemoglobin for electrophoresis, and they're told they're normal, when in fact the workup is incomplete. I borrowed this flow sheet from ACOG, and we're working on making one specific to us. But as you see here, the first step is to look at CBC and red blood cell indices. Patients of African descent should go straight to hemoglobin electrophoresis if it's never been done. Patients of Southeast Asian or Mediterranean descent, think about anemia, then hemoglobin electrophoresis, and if that's normal, DNA testing. These tests are expensive, and as I've said a couple of times, genetic counseling is happy to walk the patients through, see if they've been screened before and what their family history is. Take-home points from this talk include to offer all women genetic carrier screening, ideally pre-pregnancy. Start with CBC and red blood cell indices, specifically looking at the MCV. Triage results based upon ethnicity and the red blood cell indices. Then hemoglobin electrophoresis and ferritin. Women can have both iron deficiency anemia and a hemoglobinopathy. Normal electrophoresis excludes beta thalassemia and structural variants, and by that I mean sickle cell anemia. You can only exclude alpha thalassemia with DNA testing, and partners to carrier women should be offered counseling and testing.